Hello, I am Dr. Robert Bastian from Laryngopedia and Bastian Voice Institute. I'm here to talk about little growths in the throat, and especially in the larynx or voice box that sits right here. And if you want to understand better what we'll be looking at throughout this video, you can check out my video called Introduction to Larynx and Pharynx Anatomy, and it'll explain all of this to you, and it is found in a link below. Now, in comparison with what normal vocal cords look like, they are smooth and satiny and uniform. So these right here, these two white bands, smooth, white, and satiny. The little growths we're talking about look like tiny cauliflowers or a kind of a shag carpet-like looking area on the vocal cords. These are called by various names, all referring to the same thing. Laryngeal papillomas, laryngeal papillomatosis, RRP, or recurrent respiratory papillomatosis. I want to give you a survey of the subject, and keep in mind that there are 3 points of optimism, but they come at the end of my discussion, so just bear with me until we get to the good news near the end. Also, the images I'm going to show you are very small lesions, but they will look big to you on this video because of tremendous magnification. Well, first, these little lesions are caused by chronic infection with the human papilloma virus, also known as HPV. HPV is very common. It's ubiquitous. It's a group of 150 or more closely related variations or subtypes of the same virus. In fact, subtypes number 1, 2, and 4 cause the common wart, such as you might develop on a finger. Well, a majority of the population encounters the human papillomavirus randomly in the environment or sometimes via sexual activity. But of those exposed, the majority of people clear away the virus within a couple of years. They take care of it themselves. And a lot of them never know they were even infected. Some people with perfectly good immune systems appear to have a chink in their armor, like a little chink. Good armor, but one little chink. That allows these little lesions to appear. When they do appear, we call them papillomas in the larynx or condylomas or genital warts in that area. They appear to be able to be contracted as well coming through the birth canal, causing difficulty in early childhood or later in life as an adult. It's usually an acquired infection. The main subtypes found in the larynx are types 6 and 11. Many persons with RRP do not know their subtype, and in many clinics, subtyping isn't part of the workup. On the other hand, my colleagues and I have been subtyping very specifically for at least 25 years, and that's unusual. And in our very large caseload, we have identified a total so far of 11 subtypes that cause laryngeal lesions. And in fact, the article describing this large caseload is also linked below the video window. Now, in this video, I am talking about larynx disease expressed in adults. Disease in children tends to occur very early in childhood. The lesions recur more rapidly after treatment, and there are some other differences. So again, this video is really talking to adults with RRP. If you are an adult with RRP and you read about children on the internet, you'll get a completely wrong idea of what is ahead for you. The primary symptom of RRP in adults is voice change or loss, and rarely, in severe or neglected cases, noisy breathing. Rarely, what are referred to as high-risk subtypes of HPV, like 16 and 18, may induce a larynx cancer, but that's pretty uncommon. And that cancer is typically very treatable. Surgery for the benign lesions, the papillomas, is the current mainstay of treatment, and that surgery is quite simple. It's performed through the mouth, and it's in an outpatient operating room, so there's no hospitalization involved. And in recent years, we have 2 different in-office laser options for various circumstances. When papillomas are removed or vaporized using a laser, and that again is standard treatment currently, they virtually, unfortunately, always grow back eventually. That's why a big part of the name for the disorder is the word recurrent, RRP, recurrent respiratory papillomatosis. Now, the tempo of return or recurrence varies between people. Surgery may be needed every 6 months or once a year or even every 2 years. So that's the basic idea of recurrence. Now, once in a while, after an upper respiratory infection, there can be a time of rapid growth. I call it a bloom time. But whatever the interval between surgeries, if it is to be repeated, that surgery must be extremely high quality, very precise. That means that the disease is removed, but good tissue is not damaged. And that way, when a cure is found, which I believe it will be, a very good voice will still be there and available after all of the lesions are cleared away. Now, a little bit more about surgical precision. Think of papillomas as leaves in the fall scattered on the lawn. There are only a few scattered ones in one area, but the wind may have piled them up in quite a pile in other areas. So the surgeon has to know how to rake the leaves from the lawn without damaging the grass. What you want is meticulous and very complete removal, but it's got to be conservative. It's what I call a basement membrane peel. Now, the methods can include the carbon dioxide laser, the CO2 laser, cold methods with tiny instruments. There's something called a suction microdebrider, and then thulium and pulsed KTP lasers. Our doctors use all of these methods on occasion, and as mentioned, we do some of them in the office and some of them in the operating room. The fundamental point, though, about surgery is that it's not the tool, but the surgeon and his or her understanding and precision that make the difference. A very fine surgeon can get really good results with various tools. So you should make sure to check out your surgeon more than you check out the tools being used. Now, OR removal in our circumstance is thought of as a kind of 99% removal, just a very meticulous and complete removal. And we think of the office procedures as being a little bit more major reduction of the procedure, maybe a 70 or 75%, unless the lesion is very minimal and focal. Now, those of us who have large patient populations with RRP, like the doctors I work with, we also use adjuvants. What's an adjuvant? It's a medicine that plays a supporting or an auxiliary role to the surgery. Now, our group has not only used our current main options, which are cidofovir and bevacizumab, but we also have used many others in the past: I3C, indole 3-carbinol, DIM, Celebrex or celecoxib, mumps antigen, candida antigen, artemisinin used for malaria, and interferon. We've used all of those. Now, most of these medications are injected in tiny amounts into the vocal cords at the end of the surgical removal. So you can see how hard we're looking for something better than just repeating surgery over and over. Now, we get to the optimism. First, some patients do surprisingly well. If you look at a large caseload like ours, there are people who have undergone just a few surgical procedures and they appear to be cured. And that could be you. Now, we're slow to say the word cured, and it really should be in quotation marks. Instead, we more often use the term long-term remission. Now, we've seen this apparent cure or long-term remission after surgery all by itself. Very meticulous surgery done a few times, and the person seems to be cured, and that would be not just the surgery, but that would be their immune system. We've also seen this kind of long-term remission or apparent cure with the use of various adjuvants, both cidofovir and bevacizumab. So it's hard for us to say that one adjuvant wins over all the rest, because sometimes surgery alone has given us great results. So the point is, you need to be somewhere where people have had experience with a large number of ideas and options, and they can then individualize to you. And unfortunately, in spite of some reports that just look too good to be true, adjuvants, we think, do not appear to work the same for everyone. And that applies to our patients' opinion and also the surgeons that work together at Bastian Voice Institute. A second point of optimism is about the vaccines for HPV. There is one that covers 4 subtypes and one now that covers 9 subtypes. And the common recommendation is that young people everywhere be vaccinated in the early teens. The expectation then is that over time this will very much diminish the rate of infection and the number of people with HPV infection in all locations of the body. And some people are also vaccinating people who already have RRP, though there is controversy surrounding that subject that's beyond the scope of this video. Again, that would be a point of individualization for you. Now, third point of optimism. We are living in an era of unprecedented strides in biotechnology. I like to believe that there will be a cure in sight. Whether that means a few years or decades, I don't know, but I just feel that there's going to be a cure coming. So you just need to make sure that you manage the disease with a lot of precision surgery so that when that cure comes, you still have a very good voice. Well, a little aside about how you may have contracted the disease, this bothers people quite a bit, and I would just say the answer is often unknown with any specificity. And in a way, it's moot because the treatment is going to be the same. And keep in mind that laryngeal disease does not appear to be particularly infectious, even by close contact. We doctors take some precautions, of course, in surgery when we're manipulating the papillomas, but other than that, there appears to be no risk to being in the same room, giving hugs, or even spread from one larynx to another between spouses. As there is for all things, you'll find some different nuances of thinking in different experts. Well, there are a few major decisions that a person, if you're brand new to this subject and you're just about to embark on treatment, you need to make a few decisions. First decision is, do you want to be subtyped? We recommend it. It costs about $200 and it only needs to be done once. And the reason we like it is that it helps us to decide if the person needs to be seen on a highly regimented follow-up basis. If they have a higher risk subtype, even when the voice is still okay, higher risk subtypes we see on a regular schedule. If they have low risk subtypes, then we basically see them when they need us because of hoarseness. So that's question number 1, subtype or no. Question number 2 is vaccinate. Should you get the vaccination or not? And that requires an individual discussion because there are pros and cons, and the reasons to say no or yes may be different in different individuals. And again, it's a bigger subject than I want to handle here. Now here's a third decision, and it's probably the biggest one right at the start, or a bigger one. Do you want to proceed with curative mode? In other words, do you want to proceed not as a cure that we're going to cure you, but in that sort of a mindset that we're going to go in curative mode or in management mode? This is completely your decision. Early in our work with new patients, we offer these 2 approach options. So, for example, if a person is young and being seen very early after the start of disease, and if they want to take a shot at long-term remission, thinking, well, even if I have just 1 surgery every 2 years, that's a lot of surgeries if I live 50 years. So those young people or some other people, they say, I'd like to take a shot at long-term remission. If so, we might do 3 surgical procedures about 6 weeks apart as an outpatient and using one of the adjuvants. So the person might be coming to the OR for procedure 2 and they have a great voice. So why do this so soon? Well, because we're trying to hit the disease while it's down and remove even very small amounts of disease and then re-inject with the adjuvant, either cidofovir or bevacizumab as of this moment. So we want to find out in this curative mode series, do we seem to heal up areas that don't recur? In other words, are we winning a little bit of territory? Or sometimes we don't really heal up a lot of the disease, but we seem to tame it or make it lazier in returning. So if we seem to make tremendous progress in those 3 procedures 6 weeks apart, sometimes we continue another 1 or 2. Now, in some people, we do 3 procedures with cidofovir, and then we do 3 procedures with Avastin, each approximately 6 weeks apart, just to see, can we put you into that long-term remission or very lazy disease? Well, if we do that kind of curative mode approach and the disease just keeps coming back and it doesn't seem like we've really won a lot of territory or made huge progress, then we switch over to what we call management mode, where we only operate at your request. As long as you don't have a high-risk subtype, we just basically see you when you need a better voice, and sometimes we do that once a year and as needed. So after the question of subtyping, vaccination, and curative versus management mode, the last main decision is whether to treat the lesions in a standard operating room setting, meaning an outpatient operating room, or in an office video endoscopy procedure room. Curative mode for us almost always means the procedures are done in the operating room, because we can do that much more meticulous approach. It's like taking all of the furniture out of the room and sweeping in every corner. And we also use an adjuvant, and it's easier in the operating room to really distribute that adjuvant medication everywhere. It's a little harder to do in the office. We consider the office laser less definitive. It's like leaving some large pieces of equipment in the room and sweeping around them and under them and that kind of thing. The office, though, can be very good if the disease is really minimal or very circumscribed. Otherwise, we think of the office laser as a management tool. If you have just gotten a diagnosis of RRP, this information can seem like a lot. You might say, enough for now, or you might want to mull over what I've talked about and then watch this video again on Laryngopedia or YouTube with a family member or friend. And it can seem very threatening to learn that you have this disease process, and yet remember that many people do really well. So let's keep perspective about your prospects and stay optimistic. Repetition can be good, so here is a quick rundown of what we've talked about. First of all, laryngeal papillomas are a response to the human papillomavirus found widely in human populations. The immune system of many or most people who are infected can clear the virus after a couple of years, and sometimes they never know they even had it. If the virus persists and causes lesions, consider finding out your exact subtype, because it helps to simplify decisions about how to follow up and make the plans for future procedures or visits with your surgeon. A small percentage who initially seem unable to clear the virus and they arrive for medical attention do seem to be able to go on to cure, or long-term remission after a few procedures, and again, that might be you. Of those who continue to have recurrences that need treatment, quite a few can go to less disease and lazier disease than they had at the very first visit. In other words, you can calm down the disease process via meticulous surgery and an adjuvant medicine injected in tiny amounts into the vocal cords after removal of the lesions. You can work together with your surgeon in what we call either curative mode, that is undergoing several treatments relatively close together even while you have a good voice, to see if you can banish the disease or make it lazier and slower to return. That means a series of outpatient surgeries 6 weeks apart through the mouth using microscope, laser, and so forth, and a medication. If your disease stubbornly returns despite trying curative mode, you can move over to what we call management mode. There, we just see you when you need us. Think in terms of maybe 1 surgical procedure per year, or maybe in 6 months, or maybe in 2 years. The interval can vary widely. You just come in for treatment when your vocal needs dictate. You get hoarse enough to say, okay, I need a better voice again. Vet your surgeon more than the tools, though it is reassuring if your surgeon has available not only the carbon dioxide, but also thulium, KTP lasers, microdebrider, and it's also reassuring if he or she can offer treatment in OR and in office. To find that person, you might look at the Find a Practitioner page on the RRP Foundation's website that is linked below, or you can call the triage nurse of nearby large ENT groups and ask if one of their doctors has a special interest in this problem. And maybe you could inquire as well about the size of his or her caseload and whether it's mainly children or mainly adults. And then lastly, stay optimistic, as there has never, I mean, nobody wants this problem, but there has never been a better time in history, if you have to have it, than now. Well, thanks for listening, and please try not to worry. For more information, again, see the links below, and all good wishes to you.